Good morning, class. Today we're going to talk about Chapter 39 for the structure, function, and disorders of the integument. So there are many different types of skin dysfunctions that you may come across during your nursing career, and one of them can be a macule. Macules are those flat areas that you see on your skin, such as freckles or even what they call nevi, which is flat moles, petechiae. Those type of things is what you may see for a macule. Now, a papule is something that you will find that is more elevated, such as a wart or those elevated moles that you may come across. Another type of skin dysfunction that you may want to pay close attention to that you may see somewhere else is the wheals. Those are elevated, irregular shaped areas that you can see if you ever had an insect bite or have gotten hives. Those are type of wheals that you may see. A nodule is an elevated but firm lesion that you will see. These guys are usually about 1 to 2 centimeters in diameter. There is a vesicle, which is kind of like almost like a nodule, except for that these are filled with fluid, and such as if you ever seen chickenpox or shingles, that's what a vesicle would look like. A pustule is an elevated superficial lesion similar to the vesicle, but instead of being filled with, I should say the vesicle is filled with serous fluid, meaning it is more kind of more with pinkish stuff in it. And then whereas a pustule is more filled with purulent fluid, hence why we call it pustule. Sometimes you'll see that more with acne. If you ever popped a zit, you know what comes out. So kind of gross, but yet that's kind of what your pustules will look like. And I think we will go on and we'll talk about ulcers on the next slides, but I just wanted to point out those few different types of skin dysfunctions that you may come across, or what you really want to know for maybe a quiz or an exam. So now pressure ulcers. Pressure ulcers result from an unrelieved pressure on the skin. So for example, your patients that are in the hospital, think about it. Are they up and out of bed all the time like you and I are? No. They pretty much stay in bed, and they're usually flat on their back. So they are not up and moving. So the pressure on these pressure points, such as your heel, your coccyx, your shoulders, the back of your head, those type of areas are more at risk for developing these pressure ulcers because you're not relieving any pressure on that skin. Sometimes it can be even get worse, as you may say, because patients are laying in their body sweats, so they're laying in wet moisture. They may have broken a fever or become diaphoretic, and so they're laying around in this wet area. Never a good thing. Also, patients are they slide in bed, and so if they don't bend the knee area where they're laying in the bed, they will just slide down in bed, and that will cause a shearing or friction movement, which will tear the skin, and the skin's already tender already because of laying in bed, and so it will rip and cause a sore, and hence you get these pressure ulcers. So these pressure ulcers go into 4 different stages. The first stage is, if you want to consider it the better stage, we do not want to have pressure ulcers getting worse than stage 1. Stage 1 is just where you push on a reddened area and it doesn't blanch or it doesn't turn white. Then that is a stage 1 pressure ulcer. We don't like those. That means the skin is damaging and we need to get them off that site, so we rotate our patients. Usually we try to encourage our patients to move every 2 hours, and if they're not able to move every 2 hours, then we will move them for them. Stage 2 goes a little bit further. It's going down more into the subcutaneous tissue area, as well as again, it's pink. A lot of times in stage 2 pressure ulcers, this top layer of skin is broken, and then that is considered a stage 2, whereas pressure ulcer stage 1, it's not broken, it's just pink. When you move down to stage 3 pressure ulcer, you are going down further into the skin area, maybe even possibly close to the muscle area, but usually it just stops a little bit further down past the subcutaneous ulcer. So it's further than the stage 2. And then stage 4 is the worst, and that is when you're going down to the muscles past that to even to the bone area, which will actually is really sad. And these are what we want to prevent. We do not want our patients to go to stage 2, 3, or 4, but sometimes that happens due to facilities, due to people at home not being taken care of, etc. So again, pressure ulcers stage 1 is the best if you're going to consider a bust area. And so that's kind of what I was just talking about on this slide here. I just kind of jumped the gun a bit. Now, keloids. These are usually it's some kind of formation that has developed during tissue repair. It leaves some type of a scarring. We usually see this more in your dark skins, as well as from patients that have had burns. So these keloids kind of look like this that you will see, kind of almost like a claw-like formation, and it's just an abnormality due to scarring from healing process. Pruritus is a fancy word. It's a medical terminology word that you will see a lot of times. It's just fancy for itching. Instead of saying itching, though, we just like to use the word pruritus. It is the most common symptom that you will see in skin disorders. As well as it is how it works is it is carried by the specific unmyelinated C nerve fiber that is triggered by a number of these itch mediators, which makes you itch, 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 and so you scratch, scratch, scratch. And then some people scratch so much that they break the skin, and then your patients have now an infection. Because again, your skin is your best barrier to protect you from any infections. And once you break that skin, you're at greater risk for any infections. So we don't like our patients to scratch. So we usually give them those antihistamines to help relieve some of that itch factor. Interesting with pruritus is some patients will be in pain and it triggers an itch response, and so it's usually found in your lower intestines, and so we need to monitor our patients. If they're scratching a lot, we may want to assess them and see if they're having any pain in that area. That might just be the way the body is kind of trying to tolerate during pain. So we have many different disorders of the skin. Inflammatory disorders, your most common will be dermatitis or eczema. We see a lot of these in patients, and we'll go into more detail in the next few slides. But the main thing that you see with most skin disorders is the pruritus, some lesions, and of course some epidermal changes. Allergic contact dermatitis arises as a result of two essential stages. We have an induction phase, which primes and sensitizes the immune system for an allergic response, and an elicitation phase in which this response is triggered. So allergic contact dermatitis is termed a type 4 delayed hypersensitivity reaction involving a cell-mediated allergic response. Again, what you usually will see with these patients is that erythema, swelling, pruritus, and vesicular lesions. So this is kind of what you can see with allergic contact dermatitis. Also with atopic dermatitis, the skin of a patient with atopic dermatitis reacts abnormally and easily to irritants, food, and environmental allergens and becomes very itchy, which again will lead to scratching, redness, and flaky of the skin. Usually with atopic dermatitis, it is sometimes called the itch that rashes because the itchiness precedes the rash. So you will not see a rash until after the patient starts itching. It also becomes vulnerable to surface infections caused by bacteria, again because you're scratching the skin. The skin on the flexor surface of the joints, for example, inner side of your elbows and knees, are probably what you'll see most commonly for patients that have atopic dermatitis. Irritant contact dermatitis is usually a non-immunologic inflammation of the skin. Chemical irritation from acids or prolonged exposure to irritating substances can be caused by irritant contact, or can be seen with irritant contact dermatitis. And because it's just an irritant, all we really need to do is remove the stimulus. For example, a lot of nurses will start developing latex allergies because they're around latex all the time. So all we have to do is tell the nurses not to wear latex gloves, and the allergy goes away, or the irritant goes away, and they do not have that irritation anymore. Most hospitals these days do not have latex in the hospitals, which is good because of this. So most hospitals are latex free. But you need to check with your facility where you work at to see if it is or not. Stasis dermatitis is one of those that you will see in your patient's legs as a result of venous stasis, edema, or vascular trauma. And again, these are just where you're going to see some redness, itchiness, scaling, maybe even little petechiae. Petechiae is just little tiny dots, remember, flat lesions. As well as they can also become to the point where if they're not taken care of, they become ulcerated. And you will see more sores and pressure, almost looking like pressure ulcers inside. Seborrheic dermatitis is pretty much kind of like, I would call it dandruff almost. My husband has this around his around his nasal labial folds as well as his eyebrows, and so usually it's just scaly white or yellowish plaques that can develop into becoming flaky. Very hard to see on the nares in this picture, but right in the folds is some white flaky skin, and that is what the area what we're talking about. This is a stasis with the leg. It's a stasis sore that you will see due to inactivity or pressure and things like that. So we need to keep an eye on this. We do not want this to break the skin and become more ulcerated, so we need to protect the skin. Psoriasis there are many different types of psoriasis in our patients. We have basically what psoriasis is a chronic relapsing proliferative skin disorder. And usually what they look like is scaly, thick, silvery lesions that can be found anywhere, especially on the scalp, elbows, or knees. Because they are caused by a high rate of mitosis in the basal area. So it's just a high rate of the skin keeps growing and growing due to who knows what, but a lot of times some people believe it's due to stress, and you get that extra skin area in that certain locations. So I am going to pause this video and cut it here, and then I'm going to start a new video regarding the different types of psoriasis that you may come in contact with.